So prostate cancer is a malignancy. Like many other cancers, it ultimately can spread and can threaten the life of the patient. So, prostate cancer is not a good thing. But on the other hand, it's different to many other cancers in that prostate cancer can be slow growing, and it may not actually be responsible for the death of a patient. But on the other hand, thousands of patients in the UK, is about 11,000 patients each year, will die of prostate cancer, and clearly we've got to find out a way of stopping that. So prostate cancer arises in most patients in something called the peripheral zone of the prostate, and that's the bit that wraps around the edge of the bit that is mostly responsible for enlarging the prostate, the transition zone. And the peripheral zone is a bit like a thick onion skin. It wraps around the outside, and you can feel that. And that's why many prostate cancers used to be diagnosed by a finger examination. And the other thing about prostate cancer is that it can be detected through a blood test called PSA. And nowadays we use PSA or the MRI scan to detect it, because it's probably more accurate, certainly more accurate than the finger examination. And so we're moving more and more towards using scans to detect prostate cancer. So in summary, prostate cancer is a disease that affects the prostate, the male sexual organ, and it can be responsible for death, but actually for many men it's a chronic, slow processing disease. And I guess the job of prostate doctors is to try and help detect the disease, characterize the disease, work out the risk of the disease, and help men to decide whether the risk necessitates one form of treatment or another, and help them to identify which of those treatments is the right one for them. So prostate cancer treatment varies from monitoring, which is a management strategy rather than a treatment. But for low-risk disease, monitoring is often the best thing because it avoids all the side effects of treatment and yet keeps you safe. The monitoring identifies when the cancer is about to turn nasty, and then we can intervene. If you do need treatment, there are, I guess, two main categories of treatment. There's focal treatment, which is generally less invasive and only targets the area of the cancer. And then there's whole gland treatment, which targets the whole prostate because it might be a cancer that's multifocal. Within the focal treatments, we have a number of different energy sources that can be used. I personally use high intensity focused ultrasound or cryotherapy, but there's other treatments like electroporation or laser ablation, and they're all really trying to achieve the same thing, which is using energy to destroy a targeted bit of prostate. The whole gland therapies are either generally surgery or some form of radiotherapy. It might be external beam radiotherapy or seed implant brachytherapy. And the aim of whole gland therapy is basically to treat all of the prostate cells, whether they be cancer or benign, and get rid of the cancer that way. Now, if we focus for a second on focal therapy is something which is really only possible since we had multiparametric MRI, the really sophisticated tool to image the prostate and identify where the cancer is and where it is not. And then we use a biopsy to try and confirm that the bit we're worried about is a cancer, and also to provide reassurance that the other areas are definitely free of cancer. And with that information, we can then plan the treatment. Most of these focal therapies are day case procedures. They don't require any incision. They normally require a period of catheterization, just like 1 week with a catheter. And normally the risk of incontinence is very low, and erectile dysfunction is still a potential risk, but it's much less of a risk than it is if you're having surgery or radiotherapy. On the other hand, if you're needing whole gland treatment and you have to have surgery, maybe you choose surgery, surgery with the Da Vinci robot is far better than it used to be with open surgery, and it's much easier and probably more precise than doing it with the laparoscopic approach. And so it's become really the leading way of operating on the prostate. Keyhole surgery using the Da Vinci uses 6 small incisions in the abdomen. The largest one is next to the belly button, and that's where we remove the prostate in a bag at the end of the procedure. So keyhole surgery to the prostate is normally an operation that requires you to stay in hospital 1, maybe 2 nights, and you would have the catheter in afterwards again for a week. And once it's removed, your physical recovery continues, and you're probably back to full sporting activity if that's what you do after 6 weeks, and you're gradually improving all through that time. There are obviously some risks to do with incisions and a very small risk of bleeding and damage to internal organs. But the main problem after surgery is the temporary urinary incontinence, and that's leaking urine, particularly when you cough or sneeze or laugh. And although it affects many men at the beginning, over time it gets better and better and better. And on average, socially difficult incontinence is more or less over by half of the men by 3 months. And that basically means if you're using 2 or more pads per day, so that means you're completely dry or just using a safety pad as being the successful continence measure. And by the time you get to 1 year, you're looking at maybe 10 or 15% still having to use 2 or more pads, and the rest of the people obviously just using no pads or safety pad per day. So that's the main risk. The other risk is erectile dysfunction, and that affects men to a variable degree depending on what sort of operation is needed, whether we can do nerve sparing or not. And you probably need to talk to your doctor about your specific risk of that. What about radiotherapy? Well, that's another whole gland therapy, and that's delivered by a clinical oncologist. And you normally have 3 months of hormone treatment, which takes away the male hormone testosterone, so effectively gives the male menopause. And the reason they do that is to help shrink the prostate down, and that increases the success rate of radiotherapy. Radiotherapy is given either over 20 visits or 37 visits. Again, talk to your doctor about which is the relevant one for you, but mostly it's 20 visits these days. And increasingly, urologists like myself are injecting a gel spacer to move the rectum away from the prostate, and that helps to reduce the risks of the radiotherapy on the bowel. The risks of radiotherapy are a bit different to surgery. Stress incontinence is not so much of a problem, but you can get problems with the bladder being overactive or not storing urine so well. And same with the rectum, you can get bowel symptoms like frequency, urgency, and you can get leakage from both urine and feces after radiotherapy, although thankfully it's only in a relatively small proportion, maybe 15 or 20% of men getting difficult side effects after radiotherapy. Radiotherapy side effects can last a long time. So if you get them, they can be there with you for life, and they can even emerge after many years when you haven't had them. So late side effects of radiotherapy can be an issue. There's a very small increased risk of second cancers, particularly the bladder and the bowel after you've had radiotherapy. So that's really a summary of the main treatments for prostate cancer. And obviously, if you need to know more, it's best to speak to your specialist about it. So prostate cancer, like all cancers, when you first get diagnosed, you have to have some tests, and the tests show where the cancer has gone to. Has it just stayed in the gland? Has it started to spread outside of the gland into the neighboring structures? And has it spread into lymph nodes or into the bones? And we call this the process of staging, and we use the TNM staging system. The T stands for the tumor, so we're looking at whether it's contained or spreading into the associated structures. So that's T1, T2, T3, T4. So when you start the staging, the first question is, have you got localized disease, which is suitable for curative treatment? And that's what everyone wants. They want disease that can be cured. And if it starts to spread into the neighboring structures, the success rate of curative treatment gets lower and lower. And we're normally pretty confident about curing T1 and T2 disease. T3 disease, it might need more than one treatment because surgery or radiotherapy on its own sometimes is not successful, but that's when we start to combine treatments. Once you start to go into T4, then it's very difficult to cure that because it's involving the rectum or the pelvic floor, and then it's more likely to need hormonal treatment in addition to local treatments. When it starts to go into the lymph nodes, we call that N1, and that's when the disease has obviously developed the biology to spread, and in those situations you're more likely to need additional treatments, not just treatment to the prostate. You might need treatment to the prostate and the pelvic lymph nodes, but in some circumstances we'll decide that that's not suitable and you need systemic therapy, which means hormone therapy, chemotherapy, or novel anti-androgen treatments. And it's an area of research whether removing the prostate or doing radiotherapy when you've got metastatic disease is helpful. So we're studying that at the moment. Once you've got disease that's definitely in the bones, that is a situation where systemic treatment is the main form of treatment. And again, research is going on to see whether treating the prostate in those circumstances can be helpful. So the stage is very important, and it really does determine whether or not you have local treatment or systemic treatment. And so for men who've got risky features on their biopsy or their scan, other staging tests like a bone scan or a CT scan or even a PET CT scan, these tests will be arranged for you. Prostate cancer can definitely be cured. And one of the big questions is, does it need to be cured? Because first of all, men with low risk disease may not need curative treatment. They could go through a monitoring process and the treatment can be given if it's needed. But for men who've got localized disease, it's within the prostate still, or maybe it's just breaking out of the prostate, curative treatment can definitely be offered either in the form of surgery or radiotherapy typically, but in some cases, focal therapy may be appropriate. But cure is definitely the target for all men, and if they're unfortunate to have disease that has spread, only then do we say that the disease is not curable, but it's something that we can control, and we thankfully can control it for many years. The risk of reoccurrence after prostate cancer treatment depends on the risk of your disease, and so you should speak to the doctor that's looking after you about whether the disease has high risk features and what the risk of recurrence is after the treatment that you're having. And there are some risk calculators that can help with that. The main thing is after treatment, you need your PSA testing and monitoring is done. And under certain circumstances, you will have a scan of some sort, maybe an MRI scan or a PET CT scan to look for signs of recurrence. And for men who've had focal therapy or radiotherapy, you may also need a biopsy to see, is the recurrence in the prostate or is it coming somewhere else? The good news is that for men who've had radiotherapy or previous surgery, there are treatments that can be given. If you've had focal therapy, you can even have focal therapy repeated. But typically for men who've had surgery and the disease comes back, if it's just in the prostate bed, you can have radiotherapy. If you've had previous radiotherapy and the disease comes back, typically surgical removal is quite complicated and can have a lot of risks, and so not many people go through with that. But there is a chance of focal therapy being used, ablation of the prostate that's had radiation therapy in the past where the disease has come back. So that is another thing to consider. For men where the disease comes back and it's spread into other locations like the bones, then we would normally give hormone treatment coupled with either chemotherapy or a novel anti-androgen treatment.